It's time for another warm-up review. Let's get going. In which section of the brainstem is each of the cranial nerve nuclei located? So the nuclei for cranial nerves 3 and 4 are located in the midbrain. Cranial nerves 5, 6, 7, and 8 are located in the pons. Cranial nerves 9, 10, and 12 are located in the medulla. And the nuclei for cranial nerve 11 are going to be located in the spinal cord, which you can remember because cranial nerve 11 is the spinal accessory nerve. Next, which cranial nerve is responsible for each of the following actions? So first we have eyelid opening, that's going to be the ocular motor nerve, number 3. Taste from the anterior 2/3 of the tongue, that's going to be facial nerve, number 7. Head turning, that's going to be the spinal accessory nerve, number 11. Muscles of mastication, that's going to be the trigeminal, number 5. Balance is going to be the vestibulocochlear nerve, that's going to be cranial nerve 8. And then monitored carotid body and sinus chemo and baroreceptors, that's going to be the glossopharyngeal nerve, cranial nerve number 9. Next, which regions of the brain compose the limbic system? So that's going to be the amygdala, the septal nucleus, the mammillary bodies, the fornix, the hippocampus, and the cingulate gyrus. That's it for the warm-up. Let's get to that lecture now.
In this video, we're going to be talking about drug metabolism. This is where our bodies perform some kind of chemical reaction in the drug, which usually inactivates it. Or drug metabolism could actually activate the drug. Some medications are actually prodrugs, which just mean they're administered as inactive compounds, and when the body metabolizes them, they become active. But eventually, even those drugs are going to undergo further metabolism and become inactivated. There are two basic types of drug metabolism reactions, which we call phase 1 reactions and phase 2 reactions. Now, you don't have to go through both phase 1 and phase 2, and you don't have to go through them in order either. You can do a phase 2 reaction first, or some drugs only go through phase 1 or only go through phase 2. Phase 1 reactions are hydrolysis, oxidation, and reduction. These kind of reactions result in slightly polar, water-soluble metabolites, which are often still active. Occasionally, phase 1 will inactivate a drug, but sometimes phase 1 reactions can activate a drug and make it more potent, like converting a prodrug into the active drug. Sometimes phase 1 metabolism can actually make a safe drug toxic. For instance, methanol undergoes oxidation, which is a phase 1 reaction. It undergoes oxidation to become formaldehyde, which is even more toxic than methanol was to begin with. And then phase 2 reactions include things like methylation, acetylation, glucuronidation, or sulfation. These are all examples of conjugation reactions. Conjugation means that you're joining the drug to some other molecule, like adding a methyl group or adding an acetyl group. Or you're conjugating the drug to glucuronic acid, or to sulfate, or maybe glutathione. All of these phase 2 reactions result in very polar, inactive metabolites that are easy to excrete in the urine. Those highly polar, hydrophilic molecules can't cross cell membranes very readily, which means they cannot be easily reabsorbed by the kidneys. They get trapped in the urine and then excreted. Both phase 1 and phase 2 reactions take place primarily in the liver and sometimes in the kidneys. A drug might go through phase 1 metabolism on the first pass through the liver and then go through phase 2 on the second pass. Or another drug might go through phase 2 on the first pass through the liver and then go through phase 1 on the second pass. Or it might go through both phases in one pass through the liver. It just varies from drug to drug. But in general, I want you to remember phase 1 reactions are hydrolysis, oxidation, and reduction. And they create a slightly polar molecule that is still active. In phase 2 reactions are conjugation reactions that create a very polar molecule that is inactive. There are 3 other quick bullet points that I want you to remember. First, cytochrome P450 enzymes generally perform phase 1 reactions. We'll come back to cytochrome P450 in a second, but remember, phase 1 equals P450. The second quick bullet point is that elderly patients typically lose the ability to do phase 1 metabolism first. But they can still do those phase 2 conjugation reactions like glucuronidation and acetylation, and so on. The third bullet point is that some people are what we call slow acetylators. They just don't acetylate drugs very readily. What kind of reaction was acetylation? It's a conjugation reaction, a phase 2 reaction. That means these people are going to be slow to inactivate certain drugs. So if you keep dosing the drug normally, but the patient is inactivating that drug more slowly than expected, the drug is going to build up and the patient will have a higher than average drug level. So that patient, they're at higher risk for drug toxicity and the side effects. So again, slow acetylators have higher drug levels and more risk of toxicity. So even though most people have to take a drug twice a day, for instance, some people might only need to take it once a day or every other day. Cytochrome P450 is a family of enzymes that catalyzes a huge variety of reactions. Some of the P450 enzymes are involved in things like bile acid synthesis or steroid synthesis. And then some P450 enzymes are involved with drug metabolism. You'll see it abbreviated CYP or CYP, and then you'll see a number, a letter, and then another number. So for example, one of the most important enzymes that metabolizes a bunch of different drugs is called a CYP3A4. That's a cytochrome P450, family 3, subfamily A, form 4. There are about 12 different enzymes that metabolize 85 to 90% of the drugs that we use. CYP3A4 by itself metabolizes around 50% of drugs. So what difference does all of this make clinically? Well, if you give two drugs that are both metabolized by the exact same P450 enzyme, it will take longer for both of those drugs to be inactivated because there's only so much of the enzyme to go around. So if you give both drugs at the same time, you might have increased plasma levels, or you might have a prolonged action of one or both of the drugs. So that's where drug-to-drug interactions come from. And then, apart from drug-drug interactions, sometimes drugs and foods and even herbal supplements can either inhibit P450 enzymes or induce the expression of P450 enzymes. Since these P450 enzymes can be involved in either activating or inactivating drugs, inducing P450 could either increase the drug activity or reduce the drug activity. You can look it up and figure it out for any given drug interaction, but you can't just make a blanket statement. You need to be familiar with a few drugs that are most commonly implicated in inhibiting and inducing these P450 enzymes. Let's look at these in the study guide. First is a list of well-known drugs for inhibiting cytochrome P450. This is only a partial list, but these are some of the most common, most notorious ones. There are tons of different mnemonics out there to help you remember these. In the study guide, we use the mnemonic Crack Amigos. The first C is for ciprofloxacin. R is for ritonavir, which is a protease inhibitor. This is a class effect of the protease inhibitors that are actually designed to inhibit cytochrome P450. A is for amiodarone. The second C is for cimetidine. K is for ketoconazole. And then A in Amigos is for acute alcohol use. Chronic alcohol use will actually induce P450, as we'll see in just a moment, but acutely alcohol will inhibit P450. M is for macrolides like erythromycin and clarithromycin. I is for isoniazid. G is for grapefruit juice. So again, it isn't just drugs that inhibit the drug metabolism. Diet and supplements can do it too. O is for omeprazole. S is for sulfonamides. Sulfonamides can cause a lot of side effects, but they can also inhibit cytochrome P450. Another mnemonic we like to use is pick eggs. The P is for protease inhibitors. The I is for isoniazid. The C is for cimetidine. The K, ketoconazole. E, erythromycin. G, grapefruit juice. And S is for sulfonamides. Then, on number 5 in the study guide, we have the P450 inducers. Here's the mnemonic for those. Guinness, Coronas, and PBRs induce chronic alcoholism. So first of all, the G in Guinness is for griseofulvin, which is an antifungal drug. The C in coronas is for carbamazepine, which is a seizure drug. Then, PBRs in this case does not stand for Pabst Blue Ribbon. The P stands for phenytoin, another seizure drug. B for barbiturates, and R for rifampin. And then make sure that you're making these plural. It's PBRs, because the S is for St. John's wort, which is an herbal supplement that is supposed to help treat depression. And then, if a patient decides to start taking St. John's wort on its own and doesn't tell you about it, this can induce his P450 enzymes and mess with the drug levels in lots of different medications. So again, Guinness, Coronas, and PBRs induce chronic alcoholism, because this tells you that these drugs induce P450. It also helps you to remember that chronic alcoholism will induce P450s. But remember, like we said, acute use of alcohol will actually inhibit P450 enzymes. Another mnemonic we like to use for inducers is BCG PQRS. The B is for barbiturates, the C for carbamazepine, the G is for griseofulvin, the P is for phenytoin, Q quinidine, R rifampin, S for St. John's wort, and also chronic alcohol use. Let's do a quick review to make sure you have those two lists down. This is a little game called inducer or inhibitor. Carbamazepine, that's an inducer. Clarithromycin, inhibitor, it's a macrolide. What about the two anti-TB drugs? Rifampin, inducer, and then isoniazid, inhibitor. And the antifungals, griseofulvin, inducer, ketoconazole, inhibitor. Two drugs to suppress stomach acid. Omeprazole is an inhibitor. Cimetidine, also an inhibitor. What about the two things that patients might not tell you about unless you ask? Grapefruit juice, inhibitor. St. John's wort, inducer. And some drugs commonly used for UTIs. You've got Bactrim, inhibitor because it's a sulfonamide. Ciprofloxacin, inhibitor. Chronic alcohol use, inducer. And acute alcohol use, inhibitor. What kind of metabolism reactions did we say P450 enzymes catalyze? Phase 1 or phase 2? It's phase 1. And finally, list 3 types of phase 1 reactions: hydrolysis, oxidation, and reduction. Okay, let's talk about the metabolism of ethanol. I'm sure you know that the organ that's primarily responsible for metabolism alcohol is liver, and there are 2 key enzymes that you need to remember. There's an enzyme called alcohol dehydrogenase that converts ethanol to acetaldehyde, and then an enzyme acetaldehyde dehydrogenase, which converts acetaldehyde to acetate. Pretty easy. Both of those enzymes are dehydrogenases, so they dehydrogenate. They remove hydrogen. And you have to do something with those hydrogens you're removing. So these enzymes transfer the hydrogen to NAD, which is the active form of niacin. That NAD is a cofactor, and that cofactor is a limiting reagent in alcohol metabolism. So you need to know the drugs that inhibit each of these enzymes. The first enzyme, alcohol dehydrogenase, is inhibited by a drug called famotidine. Famotidine is used to treat methanol poisoning and ethylene glycol poisoning. The second enzyme, acetaldehyde dehydrogenase, is inhibited by a drug called disulfiram, which we use to treat alcoholism. So let's talk about famotidine for just a second. Methanol and ethylene glycol are both metabolized by alcohol dehydrogenase. Methanol is a wood alcohol, and occasionally alcoholics might try to get drunk on methanol. But remember, we said that instead of getting metabolized to acetaldehyde, methanol gets metabolized to formaldehyde, which is toxic. It can cause acidosis, it can cause retinal damage and blindness, and even in relatively small doses, like 15 cc's or half a shot. So it is very dangerous. If you drank a whole bottle of methanol, you'd die. To treat methanol poisoning, we want to prevent the metabolism of methanol to formaldehyde. So we want to inhibit this enzyme, alcohol dehydrogenase. So if we give a patient fomepizole, it will inhibit alcohol dehydrogenase and prevent formation of formaldehyde. You could also give the patient a bunch of ethanol, and basically ethanol competes with methanol for the enzyme, and it slows down that formaldehyde formation. Or you could do dialysis to remove the methanol. We also said that you could use fomepizole to treat ethylene glycol poisoning. Ethylene glycol is antifreeze, right? Well, people don't get drunk on antifreeze, but apparently it does taste pretty sweet, so kids and pets will sometimes drink it if they find it. So when you drink a nice antifreeze cocktail, the ethylene glycol gets metabolized to oxalic acid and other organic acids, which again cause acidosis, a high anion gap metabolic acidosis. If you remember the mnemonic mud piles for the causes of high anion gap metabolic acidosis, the M in mud piles is for methanol and the E is for ethylene glycol. So ethylene glycol causes metabolic acidosis, and it can also lead to kidney damage, CNS problems, and heart and lung toxicity. Especially remember that kidney damage, because the oxalic acid precipitates out as calcium oxalate crystals in the urine. And again, you can prevent this by giving fomepizole to inhibit alcohol dehydrogenase, or by giving alcohol to compete for the enzyme. So that's the first enzyme. But what about the second enzyme, which is acetaldehyde dehydrogenase? We said that you could inhibit that one with a drug called disulfiram. And we said we could use that to treat chronic alcoholism. Actually, we use disulfiram to discourage alcoholics from drinking. Say you have an alcoholic in recovery and you give him disulfiram. Well, that will inhibit the acetaldehyde dehydrogenase, and if the patient relapses and starts drinking, the acetaldehyde will build up in his body. That'll cause flushing and sweating, headaches, nausea, vomiting, and hypotension. The patient will definitely not be going back to alcohol because they think it's going to make them that sick. You should also know a handful of other drugs that can cause disulfiram-like reactions, like metronidazole, which is the most important one, certain cephalosporins, procarbazine, which is a cancer drug used to treat Hodgkin lymphoma, and first-generation sulfonylureas like tolbutamide, which nobody ever uses anymore. So if you start somebody on one of these drugs, for instance, you start a patient on metronidazole for diverticulitis or something, you really need to tell that patient to avoid alcohol while they're taking it, because it might make them sick. Now it's time for the end of session quiz, so answer those questions and I'll go over the answers. Let's go through these. First question. Which hepatic phase of metabolism is lost first by geriatric patients? That's phase 1. Which phase is mediated by cytochrome P450? That's also phase 1. Next question. What medication inhibits acetaldehyde dehydrogenase? That's disulfiram. Next. What medication inhibits alcohol dehydrogenase? Fomepizole. Next, list 7 inducers of cytochrome P450. For the inducers, our mnemonic was Guinness, Coronas, and PBRs induced chronic alcoholism. Or you could use BCG PQRS. That stands for griseofulvin, carbamazepine, phenytoin, barbiturates, rifampin, St. John's wort, and chronic alcoholism. Now, list the 11 inhibitors of cytochrome P450. For the inhibitors, our mnemonic was crack amigos or pick eggs. These stand for ciprofloxacin, ritonavir and other protease inhibitors, amiodarone, cimetidine, ketoconazole, acute alcohol use, macrolides, isoniazid, grapefruit juice, omeprazole, and sulfonamides. That's it for now. We'll see you next time.
I don't always get methanol poisoning, but when I do, I prefer fomepizole. Stay thirsty, my friends.